Welcome to the Research Works podcast, live from the European Academy of Childhood Disability Conference 2024 in Bruges, Belgium. Join us for interviews with keynote speakers, world-renowned researchers and clinicians, and behind-the-scenes stories from one of the great paediatric conferences in the world.
Hello everyone. Well, today I have Dr Charlie Fairhurst here with me. He's from the Evelina London Children's Hospital in the United Kingdom, and he's the National Specialist Advisor for Children's Neurosciences at the NHS of England. Welcome. What a title.
It's that's half your podcast. Really.
I love it. Well, welcome to the podcast. And today we'll be talking about a paper that you're presenting at this conference. It's titled Interventions for Pediatric Saliva Control Issues, Comparative Efficacy and Side Effect Profiles. Love that. How about you give us a bit of a rundown? 60 seconds. Also,
I'll try 60 seconds.
We'll try that. And I'll ask you more questions. Yeah.
So we started developing a saliva control service about 25 years ago because our head speechy, the goddess of speech therapy, Helen Cockerell, and I sat down and reflected on what was most important for families.
Yes.
And they were all coming back, it's the drooling and dribbling. Can cope with everything, but I can't cope with the drooling and dribbling.
Yep.
So we set up a clinical service, developed an algorithm which we published. It then has sort of morphed into the American Academy pro forma, and also what we did in our own nice guideline development about how you intervene. So really what we did and wanted to was to stop and reflect on our practice.
Yeah.
So we looked at 480 children who came over a 5-year period in the run-up to COVID. And every single child has a formal assessment, and we look at formal outcome measures, and we see them regularly. So we did the Reed's Drooling Impact Scale, which is a 10 factors, each scoring out of 10, factor of 100, and the Drooling Rating Scale, which looks at frequency and severity.
Yes.
And so 480 children, about 50% of them were cerebral palsy, severe cerebral palsy, but then a wide variety of other challenges, autism, epileptic encephalopathy, wide variety of neurometabolic conditions, genetic conditions. And we looked at the outcomes with regards to what were we using in our panoply of management.
Okay.
So we looked at behavioural therapy. We looked at the various anticholinergic medications for effect and side effect, botulinum toxin and surgery.
Right.
So we're looking at comparators, and really the best one to think about is the Drooling Impact Scale, which is a score out of 100, because that gives you a clearest idea, a quantification of the qualitative problems.
Yes.
Everyone who's doing an intervention should be looking at outcome measures.
Yes.
So we found that there was a clinically significant difference in all the elements of therapy. Fantastic. And what we did is we looked at where we changed, because actually a multimodality therapy is very often the way to go.
Okay.
But we changed one single thing, looked at them beforehand, looked at them afterwards.
Right.
So the myofunctional therapy, where you're trying to sort of learn how to swallow, improved by a factor of about 10 out of 100.
Wow.
Similarly with inhaled anticholinergic, so using ipratropium bromide as a nebulizer or a inhaler, was improving it by about 10 or 12. The oral medications, the oral anticholinergics, which was predominantly glycopyrronium bromide, was improving things by about 20, 22 out of 100, 6 months downstream. In the dystonic children, we were using trihexyphenidyl for its side effect profile, because you get the movement and that was pretty well exactly the same. Okay. And then your more interventional side of things, botulinum toxin, for which we had over 200 children, 550 courses. So there were large numbers in all these population groups. There's probably only about 15 in the myofunctional therapy, but well over 100, 150 in each of the two anticholinergic medications, 250 children, 550 interventions in the botulinum toxin, which was improving things by about a factor of 40 out of 100, which is pretty well the similar element to the 30 children that were having surgery long-term in terms of duct transposition or duct ligation surgery.
Gosh,
so that gives you them. But we also looked at the side effect profiles as well,
Okay.
and looked at those as well. And very much in line with the dry trial. We found that actually children that came to us on hyoscine patches were having quite severe side effects. They're all hidden because, it's just a plaster.
Yes.
But it's not. Glycopyrronium and bromide, about a quarter, we're getting not insignificant side effects. But actually the side effects in botulinum toxin were very, very rare. And the clearest message that we had to a degree was looking at chest infection rates in children 6 months before injections.
Yes.
And 6 months after injections, because this is a population that get chest infection.
That's right, yeah.
And if you give the injections and you have a chest infection afterwards, that's a side effect of the botulinum toxin.
Yeah.
But actually the rates of chest infection were about 5 to 10 times increased in the 6 months pre-injection than they were post.
Wow.
And then we had 5 children that were on PICU, chest infections in the 6 months beforehand. We had no children that needed to go to PICU in the 6 months afterwards.
Wow.
So very clear elements of actually when you're thinking about side effects, you need to think about your population as well.
Yes.
So that's what, the story comes from that.
That's an amazing piece of work. And I mean, to go back to the fact that you started a clinic 25 years ago to really to look at this population, and as a result, you do have this wealth of data that you can look from and learn from. I think there's so much strength in this kind of data at the moment, isn't there? That clinical data, real life, what does it look like?
It's real world data. It's vitally important.
It's beautiful. It really is, because there's it's life. And we know for these children, there's so many factors that affect it. And like you said, we've got to think about the population. If you think about saliva control, let's talk a little bit about, in the first place, when it comes to saliva control and drooling, why does it affect some children more than others? Do we kind of know why? What are the factors that affect that?
So, again, as with everything, it's massively multifactorial.
Yeah.
So a lot of the children have swallowing difficulties.
Yes.
A lot of children have problems with posture.
Yes.
In terms of head control, head positioning, mouth closure. It's very rarely that you're actually producing more saliva.
Right.
Unless there are two populations that fundamentally do produce more saliva. And we all produce about 1.5 litres of saliva every single day.
Do we really?
But you and I, we just swallow 2-3 times a minute. We just roll it up with our tongue, flick it down our palate and swallow it.
Yes.
But if you don't have that capacity, if your bulbar muscles are not there, it's a real challenge. Anyway, back. Two populations, your dystonic and dyskinetic cerebral palsy, or dystonic dyskinetic movement disorder population, where your tongue's moving the whole time, stimulates your saliva gland production.
Sure.
The other ones there's a variety of children with epileptic encephalopathies that are on medication like clobazam or clonazepam that really are like sticking napalm on your fire.
Okay.
That will really make your what we call hypersialia or production of saliva increase up. But apart from that, it's really associated with, can I swallow? How good's my swallowing? There was a population of probably about, out of our 483, there were about 20 to 30 children with isolated saliva control difficulties that were neurologically normal, developmentally normal, did have some problems with the phonetic structure of their speech because they had a mouthful of water, but otherwise were developmentally normal. So that's a very small population. And when you're feeding in a population of 8 to 9 million into a unit, you sort of see those.
Right.
But there are very much your big numbers are your children with cerebral palsy, autism, and epileptic encephalopathy.
With all those different factors that influence how a child might present and I guess functionally what that might look like, imagine knowing the reasons behind it is an important pathway to what kind of interventions you would trial. What's the process that you would go through that? And I know this is it's complex. I do know that, but you've got your medications, you've got the inhalation, you've got the therapy, you've got botulinum toxin, and you've got surgery. So, how do you approach the kind of interventions for these children? Is it
the most important thing, as with everything in childhood onset disability, is assessing properly. Yeah. So and never assess by yourself.
Yeah.
So God bless them. An ENT surgeon that runs a saliva control service by themselves in a back just isn't going to work.
No.
You need to have really good speech and language therapy.
Yes.
You need to to have somebody in the clinic who understands the sort of wider developmental and the neurological aspects, you need to have an ENT surgeon.
Yes.
And ideally, if you've got a dentist. So it's a multidisciplinary approach. You've got to get those foundations right before then you can consider. And it's really a question of a discussion. The parents are key. The child, if they can communicate, is also key. So you make a decision together, as we all do in our goal setting. And children with a very mild saliva control difficulty, you might try one of those factors where you're reducing AOIT, but it's much less invasive.
Yes.
So somebody who can do a myofunctional therapy program, which is quite intensive.
Yes.
That's a good thing to do.
Yes.
And very often those are the isolated saliva control difficulties.
I see.
Ipratropium bromide is a very normal thing. A child having an asthma pump in a primary school class is normal.
Yeah.
Because in a class of 30, you're going to have half a dozen.
Pretty acceptable.
Possibly.
People understand it. They see it. Yeah.
And so you're using that for saliva control difficulties rather than asthma.
Yes.
Children with sort of moderate to severe saliva control, your first line is probably your anticholinergic medication, which most widely licensed is glycopyrronium bromide, and then botulinum toxin. Sometimes you might go straight. Sometimes, as I said, it's a multimodality.
Sure.
So you might use glycopyrronium with botulinum toxin. As that's working, when that's working best, you might come down with the glycopyrronium and then need to go up again.
Yes.
Because we found that it lasts around 6 months on average.
Okay.
Botulinum toxin.
Okay. Kind of that's, we understand botulinum toxin being, we often use it in muscle and all that kind of thing, but here, same sort of thing, it's transient, I suppose, for that period of time. Does that, like when you put botulinum toxin in muscle, is there a window of opportunity there? Is there things that people need to focus on or think about during those times to make use of that? Or is it more just, let's see?
So you're using it for symptomatic control. You're never going to, time is the best management in many ways.
Yeah.
So there are an awful lot of children that just improve over time with regards to their saliva control difficulties. And sometimes you're just nudging and nurdling down the line with regards to that.
What about like pre-winter? When is that a timing? Yeah?
Spot on.
Yeah.
I wish you were. God, anyway.
I'm a thinker.
Fantastic. Well done, that girl.
Thank you.
Exactly. So we do have some families where you look at the quality of life and the impact that actually they can cope over the summer months because you know what? Everything dries up a little bit. It's not a problem. But in winter, particularly if you've got an element of posterior ciliary rather than purely anterior ciliary. So anterior, coming out the front, you might get nasty rashes and sores under here, which are bad in the winter. But equally, in the winter, you might, if it pours down the back and into your larynx and pharynx and goes down into your lungs, you're much more likely to get chest infections. So we do some children where actually the families can cope over the summer months, but come in the UK, which is the opposite from where you are in Australia, but in the UK, sort of coming into the end of September into October, November, we'll be thinking of doing a course to see them over the winter months.
Yeah, sure. Does it have any role or is there any impact there for children who tend to have PEGs, for example, and how they receive their nutrition? Has that got any role to play in particular?
Not really. I think it's really important that if you're going to use something like botulinum, what you don't want to do is, because you're mitigating. You're not curing with any sort of saliva control intervention. So what you don't want to do is to overly thicken the secretions. Particularly as anticholinergic medication has problems with gastrointestinal tract in terms of constipation and urinary retention is the main sort of side effect profile. So you've got to be slightly cautious and think holistically of the well-being of that child. We never do all the saliva glands. There's a whole series of small ones. We tend to focus on the submandibular and parotid. And if you look at the Sepexi trial, they do 2 parotids, 2 submandibular. We tend to do 1, but that's just our personal practice.
Okay.
Saliva is important for keeping your mouth healthy. Yeah. What's going on in your esophagus.
Yes.
And your higher sort of elements of digestive system. So don't overdo it.
Yes.
And
there is a reason and purpose to it all. Yeah, and everything in balance. What about, I guess, a final thing to touch on is the surgical method. Remind me again how many times that happened in your sample?
So we had 483, as I said. 31 of our children had went on to surgery. So again, our surgeons are cautious. Yeah. And if you look internationally, some surgical units still do it relatively frequently.
Okay.
And certainly we've discussed with the ENT college and experts within the UK, and they tend to still go down an ENT intervention. So whether that's reorganizing the plumbing from the saliva glands, or debulking the saliva glands, or excising the saliva glands. It's not without risk. Yeah. It's not without side effects. And actually what we've tend to find is if you do it very early in children before you have a mature oral motor cavity, you can actually lose the benefit. It tends to recur as a problem. So we tend to sort of push into adolescence and do it in a child who's got a safe swallow.
Yes.
And we tend to recommend duct transpositional surgery predominantly.
Okay.
With some excision, plus or minus. We leave that to the end. ENT surgeons have got to do something.
I know, we'll leave them with a few of these things to do. And what about, I guess, a final point? I know we're going slightly over, but I think it's really important to note is what tends to happen for these kids as they sort of age out of the system, they go into adulthood. Do we know whether these interventions continue? Is there a clinic like yours in adult land?
There are clinics in adult land, and again, it depends on where your international pathways and processes, and that's where my sort of NHS England role comes in, to try and think about how we transition, what age do we, but there are specialty clinics that it's licensed for use in adults. Botulinum toxin, glycopyrronium bromide is licensed for use in adults as well. But actually, as with everything in adult life, it's a little bit precarious.
Yeah, I know.
Finding the experts that are interested in child onset disorders is a real challenge.
Because this is not exactly something that disappears when they reach a certain age. And hopefully we can find, through work like yours and the clinic that you've established and all the guidelines, is to say, okay, what we can do, what works for that particular child, and hopefully have something for them to take into adult land of what works.
And most of the ENT surgeons do cover pediatrics and adults, so that is quite useful. Yeah, for sure. If they've got an interest.
Wow. Thank you very much for sharing that with me today. That was brilliant.
Pleasure.
I loved that conversation. Thank you. So to all of our listeners, I really hope that was as enjoyable for you as it was for me. There is actually a paper that Charlie has published on this as well. So I'll pop a link up there for you so you've got that as a bit of a guide too. But I'm sure we'll speak to you again soon. I think we've got much more to talk about. But enjoy the rest of the conference. We'll talk to you all again really soon. Bye.
Bye.